thank you everyone for joining me for what is probably the third installment of basic monitoring, but no time like the present, isn't that right? So today I want to talk a little bit about why we monitor animals when they're sedated or anesthetized. I'll talk about the different types of equipment that we use for that and some of the basic technology behind how they work. Now, specifics on troubleshooting, monitoring, and advanced technology of these modalities, I will discuss at a later point, and we will also discuss how to fix those problems. But today we're just going to focus on how they work and why we use them. So why do we monitor animals that are sedated or anesthetized? Number one, provide an idea of trends over time. So anesthesia and sedation monitoring is not just about looking at something that happens every 5 minutes. What you want to try to understand is that over the course of time, how is your patient responding to surgery? How is your patient responding to fluid therapy? How is your patient responding to your analgesic and pain relieving protocol? So by monitoring vitals such as blood pressure, heart rate, the respiratory rate, you're going to get an idea of what is happening over time, and that's going to tell you in a 15-minute period, in a 1-hour period, do I need to make some type of change, or can I keep going because this is working for me? So provide an idea of trends over time. It's not just one look, it's the whole thing. The job of the anesthetist is monitoring, so that's why it matters. Indicate health status. So this is almost a given, right? So by using monitoring equipment that tells you about heart rate, blood pressure, oxygen saturation, temperature, you're going to get kind of little peeks into your patient's health. And based on some of those parameters, you might be able to make specific diagnoses about what is going on. Did the heart rate just increase? Okay, well maybe the patient is awake, or maybe the patient is painful. Maybe it also bled a ton. Is there any blood on the floor, or is the animal really hot? So these can all give you kind of little indicators about what's going on in the inside. Creating an anesthetic or a sedation record. So this is something that we should be doing for all patients that are sedated or anesthetized. And by monitoring vitals, by using basic equipment, you can use those parameters to go into a record. And this basically provides a record of the quality of your anesthetic care. So whether you're monitoring something on an electronic record or a paper record, or you're not using a record at all and you're just looking, I want you to think of the anesthetic record as proof that you care for the animal in a quality way. So if you choose not to maintain your record, or there are huge gaps in your record, what that might say to other people is, I wasn't watching the animal. So just keep that in mind. What would you want for your pet, right? And this kind of ties in with number 3, but creating liability. So the nice thing about having an anesthetic record and monitoring animals is that over time we get trends, we get to see what's happening with our patient, and we have a way to tell what happened and what types of interventions we made if there were any problems. It would never hold up in court to say that you did not monitor an animal or did not have a record when there was a complication that occurred. That would be a really easy way to upset someone and get someone in a lot of trouble. So try to do your best to make sure that you have an accurate, up-to-date record. And if for any reason there is a gap, like there was a 911 emergency, or you had to do an intervention with the patient that led to a gap, or you moved the patient to a room and there was a 10-minute gap in the record, make sure you made a note of that, so that way you're going to be covered in case of an emergency. Minimum standard of care for sedated and anesthetized patients when it comes to monitoring. When you have a sedated patient, I want you to put on a pulse ox, a blood pressure cuff, and probably some ECGs if you can stand it. Lots of sedated animals have dynamic airway collapse, and they are going to need oxygen support. Lots of animals, when they're sedated, their blood pressure might either get really high if they get alpha 2s, or it might get really low if you ended up using alfaxalone IV. So just keep that in mind. And certain combination of drugs will change the heart rate and change the rhythm, so try to do that as well. Anesthetized patients, everything goes on them. ECG, end-tidal CO2, blood pressure, pulse ox, temperature, and the blood pressure measurement can either be non-invasive, Doppler, or invasive. So minimum standard of care is to put on some monitoring. Remember that your job as the anesthetist is to monitor the patient. You have other jobs too, like getting things for the surgeon and setting up drapes and getting the room cleaned. But think of this as, one of your other jobs that you need to do, and you need to do it just as well. So that's kind of the deal on basic monitoring about why we do it. Now I'm going to talk about some of the pieces of equipment that we use to do that and kind of how they work. And the first one I'm going to talk about is ECG. Okay, ECG, this stands for Electrocardiogram. I'm going to draw a picture here. Very fake, totally anatomically correct heart over here. Okay, so electrocardiogram. So the ECG basically tells you about the patient's electrical activity in their heart. So it can tell you about electrical activity and it gives you a heart rate. The ECG does not tell you that the animal is alive. So remember that one of our arrest rhythms in CPR is called pulsus electrical activity. So basically what that is the electricity in the heart without actual pumping. So don't use an ECG to say your patient is alive. You need to use it in conjunction with other things like blood pressure and capnography. So ECG tells us about the electrical axis of the heart. And basically how that works is through what is known as Einthoven's triangle. And what Einthoven's triangle does is that it puts 3 different measurement points on the body, and depending on what direction you're reading the electrical activity of the heart, you're going to get a different snapshot of the electrical activity. So we know that the heart depolarizes or sends its electrical activity from top to bottom, right? So it's going to go from the right atrium down the middle of the 2 atria, down the ventricles, and kind of up the side. You probably remember this from Recover CPR. So from top to bottom. And basically what's going to happen on your ECG, let me just draw this guy out here. PQRST. So that's what you usually see on the monitor, right? When the heart depolarizes towards a positive lead, like this or like that, when it depolarizes in that direction, you're going to get a positive deflection on the monitor. And that's why when we set lead 2 on the monitor, which is read right arm to left leg, negative to positive, the heart depolarizes top to bottom, it depolarizes towards the leg, you get a positive deflection because you're looking at it from that way. Now, if you select lead 1, what you're going to do is you're going to look at the electrical activity kind of across this way instead of down. So if you're looking this way, if you're reading this way and the heart depolarizes this way, is the QRST going to go up? No, it will not. It usually ends up being inverted. So in dogs and cats, we usually end up setting lead 2. In horses and cows, we usually end up setting lead 1, in case you were interested. So that's the ECG. I will erase this diagram for now. Now, the ECG can tell you about heart rate, it can tell you about heart rhythm. Depending on the appearance of the PQRST, you might also be able to tell about certain types of chamber enlargement or diseases that the animal has. So that's one reason why it might be important. And the ECG can tell you about anesthetic depth, so if they're light or they're really, really deep. It can tell you about pain or nociception, so if they're really uncomfortable, they might get a little tachycardic, right, or have a bit of a response. And the ECG can also tell you about fluid or volume status. So animals that are really dehydrated might get tachycardic, so sometimes those animals benefit from a fluid bolus. So I use the ECG to tell me about depth, I use it to tell me about comfort level, and I use it to tell me about certain diseases. But I don't use it to tell me if the dog or cat is alive. So I select lead 2 almost always. And then I make it so it's at a suitable size that I can just read it easily. And this tells you about depth, pain or nociception, hydration status, lots of animals have arrhythmias under anesthesia. Not all of them need to be treated. If they are hemodynamically insignificant, so basically if they're not affecting the blood pressure or how the dog or cat is doing, you don't necessarily have to treat them. And this will, the treatment will all be, of course, at the discretion of the attending veterinarian or physician, but that's kind of how that works. So that's just kind of a basic look at ECG technology. It's based on the Einthoven's triangle. It's going to give you some trends about how good the patient is feeling over time, but it doesn't tell you if they're alive because pulseless electrical activity is an arrest rhythm. The next piece of equipment I want to talk about is pulse oximetry, or SpO2. So pulse oximetry tells us the percentage of hemoglobin in the blood that are completely saturated with oxygen. Percentage hemoglobin, completely O2 saturated. So pulse oximetry gives us an indication about oxygenation status, and it also tells us the patient's heart rate, and can also tell us about the rhythm. So if the rhythm is normal, you're going to see a plethysmograph wave or a pulse oximeter wave very regularly like this. And if they have a sinus arrhythmia, maybe they're going to have like 3 or 4 and then a pause, right? And if they have other arrhythmias, maybe they have a beat, they have a pause, they have another beat quickly, and then they have a couple more. So the pulse ox can tell you about saturation, but also tells you about rhythm and heart rate, which is kind of useful, right? And the way that the pulse ox works is based on a couple of things. So the pulse ox has 2 pieces of equipment. It has a photodiode and a light emitting diode. So the light emitting diode is that red piece of equipment. And basically what happens is that when you put that light, those 2 little sensors, over a piece of tissue, light is going to pass through the tissue, and light is going to be differentially absorbed by different types of hemoglobin, deoxyhemoglobin and oxygenated hemoglobin. So I'm going to put an equation on here that you don't have to memorize, but is just to illustrate how this technology works. So there is red light and infrared light, and this is how this works. So, it doesn't work, that pen. Hooray. Okay. So pulse oximetry, light emitting diode, photo emitting diode, those lights are going to pass through tissues, and deoxygenated and oxygenated hemoglobin are going to absorb and let pass different types of light. So there is red light, which is 660 nanometers, and then there's red light, which is 940 nanometers. You don't necessarily need to know that, but it is important for a later context. So basically what happens is that when the heart contracts, the arterial bed is going to expand, kind of in a cyclical variety. And basically what's going to happen with the pulse oximeter is that the oximeter is going to measure the alternating current and the direct current of the 2 different light absorbances, which are going to tell us kind of the fraction of oxygenated and deoxygenated hemoglobin. So the alternating current is what happens during the pulsatile phase of the cycle, and the direct current is what the sessile flow in the arteries. That's what is being measured during that time. So basically what this does is that by measuring these light absorbances, this creates an equation known as R, or the R ratio. And the reason why this is important is because the R correlates to an SpO2 percentage. So let me see. Let's say you have more deoxyhemoglobin, increased deoxyhemoglobin, Basically what that means for this is that there's more red light absorbance, and there's a higher R ratio. Let's say your deoxyhemoglobin is lower, so your patient's saturating well. Decrease deoxyhemoglobin. You guessed it, less red light absorbance, decreased R ratio. So basically, the pulse oximeter is going to take this information, it's going to get the R ratio, and then it's going to take the R ratio and kind of match that up on a graph with a pulse oximeter percentage. So that's kind of how that technology works. So here are some other things I can say about pulse oximetry. Pulse oximetry in general, kind of like ECG, it is prone to artifact. So the pulse oximetry is read based off of pulsatile blood flow, right? So if the reading of the light absorbance is going to be interrupted by a disruption to flow or by something else, then your reading is going to be artifactually low. For example, if your patient is very cold or vasoconstricted, sometimes the pulse oximeter has a difficult time reading pulsatile flow in the periphery. So sometimes it gives you an artifactually low reading. There you go. The other thing is that if you move the patient and you disrupt the reading of the pulsatile flow, motion artifact will also give you an artifactually low pulse ox. So just keep that in mind. The pulse oximeter almost never reads falsely high, which is great. But that is basically how the technology works. So if the patient is still, if they're not vasoconstricted, you could probably assume that the pulse ox is reading correctly. So that's pulse oximetry. The next thing I want to talk about is end-tidal CO2 or capnography. ETCO2, capnography. Okay. So capnography tells you about rest rate, which can tell you all types of things: comfort level, temperature, response to surgical stimulus, certain types of lung diseases, rest rate, and it gives you a waveform. And the waveform can be significant for certain diseases, pattern of disease. So capnography on the monitor usually looks like something like this. Usually measured in 4 kind of different stages. 0 being kind of the baseline, so that's in between breaths. Stage 1 is the beginning of expiration, so as the animal starts to breathe out, the gas being moved by the patient is going to mix with the gas sitting in their endotracheal tube. 2 is a continued climb. 3 is what's called the alveolar plateau. So that is really kind of the emptying of the rest of the alveoli or the lung units. And then 4 is the inspiratory downstroke. So that's when the patient's breathing in again and the CO2 falls back down. So capnography, the idea behind capnography is not only to measure respiratory rate and the amount of CO2 the patient has, but capnography also tells you about cardiac output, and that is because living animals produce CO2 as a byproduct of metabolism. So that's why in CPR, when your patient is dead and there is no cardiac flow, the CO2 is really low, because we need the heart to pump that blood from the periphery to the lungs, and then at the level of the lungs, the CO2 is eliminated. So think about end-tidal capnography, not only about breathing, but about cardiac output. That's why animals with really low blood pressures will sometimes have CO2s in the 20s. It's just because the heart is not able to pump all of that CO2 from the rest of the body outward. So that's kind of capnography in a nutshell. So basically what is going to happen in terms of its measurement is that, let's say you have a dog over here. I'm not going to draw a dog. I'm going to draw a square because my drawing would be an abomination. So let's say you have your patient here, and they're connected to a CO2 unit, which I'm going to draw as something quite familiar. So you know, it attaches to the patient's breathing tube. It's endotracheal tube. It's got kind of like a tunnel, and then it's got either like a screw-on port or a line. and then it goes up to some type of monitor, which usually has a water trap, and then there's a sensor, and then this goes to a big screen monitor. And usually somewhere on the tubing, there's going to be a crosshatch waffle weave pattern, and that is called Nafion tubing. And the idea behind the Nafion tubing is that it prevents some of the risk of condensation from developing inside of the line and traveling up here to the monitor where it can damage it. So when I attach capnography to animals, I always face the line upwards. So I never let it hang to the side or down, because not only can it break, which makes your CO2 unreliable, but it can get condensation or liquid in there and then it destroys the equipment. So always face this up, okay? And basically what happens is that the machine is going to aspirate air from the endotracheal tube and use that as a sample to read the CO2 and generate the waveform. So that's basically how capnography works. So not only about breathing, but about cardiac output. Just remember that. Okay, last two things I want to talk about are going to be blood pressure through a couple different means, and then temperature, which is pretty straightforward. So the first thing I want to talk about is non-invasive blood pressure, NIBP. So blood pressure just tells you about the average flow in the arterial tree. And blood pressure is really important because this tells us about the mean perfusion that is happening in the animal. So there are all types of consequences that are associated with very high or very low blood pressure. So maintaining an adequate blood pressure is really important, and it's, one of the fundamentals of practice. One of my jobs as an anesthesiologist is to ensure oxygen delivery, and first you have to give oxygen to animals, and then you have to make sure that the heart is doing a good enough job pumping it to the tissues, because without that they die. So oxygen is very important, and the delivery of oxygen is very important, and blood pressure is one of the ways by which we accomplish that. So non-invasive blood pressure, that's a cuff measurement, okay? Cuff. The cuff is usually placed above the carpus or above the tarsus. You can also do it at the top of the tail. The cuff needs to be on its width. It needs to be about 30 to 40% the circumference of the animal's limb. And I will tell you that in clinical practice, pretty much no one gets out a ruler and then gets the cuff size that's 30 to 40%, but just try to eyeball it. If you use a big cuff on a small leg, you underestimate the blood pressure. And it will give you a lower reading than what the blood pressure actually is. If you use a small cuff on a big leg, you will overestimate the blood pressure. So this is a problem we have in animals that have wedge-shaped limbs, so like our chondrodysplastic breeds, like French bulldogs, corgis, dachshund. When the leg is like a fat little sausage and you have to put on a really big cuff to fit it, sometimes what will happen is that the cuff will slide down the leg and it doesn't fit very well. So big cuff on a small leg, it might underestimate the blood pressure. But if you pick a small cuff that might try to fit a bit better, but it doesn't really reflect the size of the patient's limb circumference, then you tend to overestimate it. So those are one of the pitfalls of that particular type of equipment, and there are ways to get around that, and one of that is invasive blood pressure, which I'll talk about in a moment. So basically how non-invasive blood pressure works is that you slap the cuff on, and hopefully it's the correct size, because that's hopefully going to give you the correct reading, or the most accurate reading. And basically what it's going to do is that it is going to inflate to a pressure far above the systolic blood pressure, which is the blood pressure generated during peak heart contraction. And basically what's going to happen is that it's going to inflate, and it's going to start letting down pressure in a stepwise fashion. And what's going to happen is that as you inflate, you're going to occlude all of the blood flow through the arteries. And as it lets down pressure, the systolic blood pressure will be red at the point at which blood flow first starts to come past the cuff, systolic. And then the blood pressure cuff is going to keep letting down pressure. And the last pressure at which flow scoots past that, the reverberations are red here and here. And this is going to be the diastolic blood pressure. So the diastolic blood pressure is the blood pressure during diastole, or the resting phase after contraction. So the systolic and the diastolic blood pressure are measured, but the mean blood pressure, or the MAP, is calculated based off an equation. And the equation is mean arterial pressure equals diastolic blood pressure plus 1/3 times systolic blood pressure minus diastolic blood pressure. So the monitor, it measures the systolic blood pressure and the diastolic blood pressure, but it calculates the mean. So of the numbers on that screen for blood pressure, the mean is the most accurate because it is calculated. And another thing I want to point out about this is that even if you don't memorize this equation, what I want you to know is this. Diastole, the resting phase after contraction, is incredibly important for determining blood pressure. You can see that diastole shows up in this equation 2 times, here and here. The heart spends 2/3 of its time in diastole. So if the diastolic phase is very long, like if the heart rate is very slow and there's lots of resting in between contraction, or there's lots of runoff that's occurring during diastole, the blood pressure gets low. So just think about how all of those things tie in together. So systole being contraction, diastole being resting, diastolic phase, very important for determination of blood pressure. So then from there, you get 3 numbers on your screen. Systolic, diastolic, mean. I like the systolic blood pressure. I also like markers that work, but I think this one is gonna work. Woohoo! Systolic blood pressure, dog or cat, needs to be greater than or equal to 90 millimeters of mercury. That tells me that the animal has enough fluid in its heart and the contraction of the heart is okay. Mean blood pressure, so the average blood pressure in the arteries, needs to be at least 60 millimeters of mercury. If the blood pressure is less than this is called hypotension. If the systolic blood pressure is greater than 140, we usually say that is hypertension. There are a lot of complications that are associated with hypotension, including decreased oxygen delivery, prolonged anesthetic recovery, blindness, brain injury, kidney injury, liver injury, decreased wound healing, immunosuppression, lots of bad things. So it's really important that we try to make the blood pressure at least 60 or at least 90 systolic. So, and there are consequences of hypertension, which I will discuss in later, but that is not usually a complication we see in animals, at least when they're anesthetized. Hypotension is much more common. So that's what I can say about non-invasive blood pressure. It's gonna run probably every 3 to 5 minutes. So it kind of gives you gradual trends over time about how the blood pressure is, like is there bleeding, is the animal reacting at all? There you go. Now, if you have a patient that's really debilitated and you want moment-to-moment accurate information, you can put a cannula in an artery and get invasive blood pressure monitoring, IBP, or arterial blood pressure. Arterial blood pressure monitoring. So, non-invasive works with a cuff or with a Doppler. But with invasive blood pressure, what you're gonna have, IV catheter is gonna go into an artery. And it's gonna be attached to fluid, filled, heparinized, with a pressure. This is a pressure symbol, pressure bag. And this is going to give moment-to-moment information. Okay, so breaking this down, what this means. So this is how this technology works. So when the heart contracts, the kinetic energy from the heart contraction is going to be stored in the elastic walls of the arteries. And the aorta is an elastic artery. So the heart contracts, the energy gets stored in the elastic walls of the aorta, and then that energy is going to travel down the arterial tree. So it's going to travel from the aorta all the way down to the feet. So there are arteries in the feet and the tail, and you put your catheter into an artery, and you'll feel it because it's pulsing, right? Kind of like the femoral pulse, but on top of the foot or on the middle of the tail. So the catheter is going to be in the artery, and that catheter is going to pick up the pressure waveform from the contraction of the heart that was spread all the way down the arterial tree. And what's going to happen is that reverberation, that energy, is going to travel in fluid-filled tubing from the artery to a transducer, where that signal is going to be converted to an electrical stimulus, and then it's going to puke out the systolic mean and the diastolic blood pressure. So because it's in an artery and it's reading each heartbeat as it happens, invasive blood pressure monitoring is the most accurate measurement you can do, and it's moment to moment. So if you have a patient that has arrhythmias, if they have a terrible lung disease, if you have an open chest surgery, knowing what the blood pressure is every single moment is going to be more helpful than a snapshot every 5 minutes. So this would be the gold standard for that particular type of patient. Gold standard. Now, not every patient needs to have an arterial line, but it can be incredibly helpful when you do need it. The other nice thing about having an artery cannulated is that you can pull a blood sample very easily, so you don't need to hold off an artery. It's pulsatile, so it fills on its own, and it's a very easy way to check blood glucose, check electrolytes, check oxygen if you have a problem with your patient. So just think of it not only as a way to monitor, but as a way to sample. So that's what I can say about invasive blood pressure monitoring. And we'll talk in later sessions about how to fix things like low blood pressure or arrhythmias, but it's kind of beyond the scope of today's talk. Okay, ECG pulse ox, capnography, two types of blood pressure. Temperature, I don't really have a way to explain how the technology on this works, but basically you can use either a temperature probe or you can use a digital thermometer. And basically what I do is that I measure the tubing of the temperature probe down to kind of the top of the rib cage, because that's almost where the stomach is, and I thread it all the way down the patient's esophagus, and I monitor the core temperature. I usually like for animals to be around 99 degrees or higher when they're anesthetized, so between like 99 and 101 degrees is totally fine. If the patient is above 103 degrees, I typically start active cooling. Now, if your patient's temperature increases 1 degree for every 5 minutes they're anesthetized, and they're panting, and they're tachycardic, and their CO2 is really high, they might have a disease called malignant hyperthermia, and you should let someone know and we will try to fix it. It's incredibly rare, but it's definitely a temperature-related hot disease that happens. Heat stroke is something similar in terms that they get really hot, but it's a different pathophysiology. So if they're above 103, I start active cooling with cold IV fluids and ice packs on body surfaces. If they're less than 97 degrees, I start active warming, so that involves forced warm air, like a bear hugger. That's the most effective way to warm patients. I will put towels or rubber mats on metal surfaces. I will use hot water blankets. You can also use like warm bags of fluids if you have like a really small patient. So kind of like hyperthermia is associated with a lot of bad problems like tachycardia, cell death, increased oxygen consumption, arrhythmias. Really low temperatures, and I'm talking like less than 90 degrees, are also associated with problems. Prolonged anesthetic recovery is the principal one. Hypothermia is the #1 cause of prolonged anesthetic recovery. And of the animals that die in the peri-anesthetic period, 61% are going to die in recovery. And things like low blood pressure, low temperature are reasons why animals can die. And that's one of the reasons why it's really important to monitor recovery, okay? So temperature less than 90 degrees, animals, their baroreceptors become less functional and they don't respond to atropine as well anymore, especially cats. That's why it's really important to keep cats warm if you're reviving them during kind of a really sick situation. And when animals get to be less than 90 degrees, they also tend to have ventricular arrhythmias and bradyarrhythmias. So just keep that in mind. Patients usually lose most of their heat within the first hour of anesthesia. So the first hour is really the most important time to be proactive. Cover up metal surfaces. Even putting a simple towel on an animal reduces radiative heat losses by 30%. So even if you can't get a blanket on them, just put a towel on them, okay? It will make a huge difference. So what I can say about all these pieces of equipment is that I talked about the basic technology of how they work, but something that I want you to keep in mind is that if we're taking good care of our equipment and we're keeping it clean, we're loosely coiling our cables at the end of every day, we're keeping the equipment secured, and we're treating it well, you should trust your equipment. Don't trust a reading that is low, high, or abnormal. Try to find out what the problem is, or if you don't know, just ask someone. Don't pretend like the problem doesn't exist. Because remember that one of the reasons why we create an anesthetic record is creating liability, and you're responsible for that patient. So it is your responsibility to at least do something. My recommendation for caring for monitors is that when they're not being used, one of the feet on the bottom should be locked so that way the monitor can't be rolled and hit something. I would recommend loosely coiling the cables, making 6 to 8 loops of the cable, 6 to 8 inch loops of the cables, and hanging them on the monitor with either Velcro or just like put them on the little hooks. Do not coil them really tightly so that they have tiny loops, because this frays electrical wires and then the equipment breaks. You should clean the ECG leads after use and make sure they're not jammed up with gel. None of the equipment, cables, or wires should have blood, feces, or body fluids on them, and they should be gently disinfected. A simple alcohol wipe would be absolutely fine if the equipment's really filthy. Otherwise, you can just use warm water. Ideally, monitoring equipment should never come into contact with the harsh chemicals used to disinfect the OR, so don't just spray the monitor with Kenalzol or with bleach, because over time that will damage the screen and the sensitive equipment, and then it breaks. So in summary, I can say for every sedated and an anesthetized patient, put some monitoring on it, understand what those parameters actually mean, what they do and don't tell you. And when you're done with your case, try to take good care of your equipment, because this stuff can last a really long time. If we're taking good care of our stuff, then we should be able to trust what our vitals are.